Hello, students. So, welcome to this session on 100 one-liners. I am Dr. Khushbu Mahajan, and I'll be taking this session for you. Now, this will be an interesting session because here we are not going to discuss in detail about the theory or anything. It would be just a quick revision for you. So, I would want you all to actively participate. So, see, this is not an exam, so don't worry if you're giving me wrong answers. Here we are there to learn. So I have made this session in a way that in each slide I've put in 3 one-liners, and since there is a lag, so that's why 3 one-liners in one slide. And I request you to put your answers in the chat box. Since these are small answers, you can quickly type them and then we can discuss. It will help you quickly revise the subject and make this session more interesting. So it would be like a rapid fire question. And if there is any associated thing that you should be knowing, I'd be talking about that. And before I forget, please like and subscribe this page and join us on the main page. So here, starting with the first 3 questions, and I see a lot of you have logged in, and so I'll wait for your answers. The first one-liner is, the layer of skin which is underdeveloped in low birth weight neonates is... Fox-Fordyce disease is a disease of what structure I mean here, and Langerhans cells are present in which layer of the skin? So let's see. Give me some inputs, give me some answers. Just write whatever you think, just whatever comes to your mind first. So perfect. A lot of you have given me the correct answer. So the layer of skin which is underdeveloped in low birth weight neonate is stratum corneum. Perfect. Because we all know that skin develops from bottom to top, and stratum corneum is the topmost layer. So in a low birth weight neonate who's born prematurely, the uppermost part of the skin layer would not be developed, and so here the answer would be stratum corneum. Okay, next question. Fox-Fordyce disease is a disease of... Give me some answers on that. Okay, so here I caught you. Fox-Fordyce disease is not a disease of sebaceous gland. Fordyce spots are disease of sebaceous gland. What is Fox-Fordyce disease? I'll give you some hints. It's seen in pubertal females. It is seen in the axilla. It appears as mildly pruritic skin-colored papules in the axilla. So Fox-Fordyce disease is a disease of... Absolutely right. It is apocrine gland. Is the apocrine gland. So the point of putting this question here was to confuse it with Fordyce spots, and some of you did get confused, so don't worry. Now you will remember Fox-Fordyce disease is for apocrine gland and Fordyce spots is sebaceous glands. Langerhans cells are present in which layer of the skin? I think some of you already gave me some answers, and most of you were correct. It is not in the stratum basale. It is stratum spinosum. So remember, there are 4 cells in my epidermis: keratinocytes, which are present in all layers of the skin; Merkel cells and melanocytes, which are present in the basal layer of the skin; and Langerhans cells, which are present in the stratum spinosum, right? So moving on to the next 3 questions. For some of you who are not able to see clearly, which type of hypersensitivity reaction is patch test? Which type of hypersensitivity reaction is patch test? Slab cheek appearance is seen in, and swimming pool granuloma is caused by. Now remember, I have placed these questions absolutely randomly, because in the exam, they don't give you topic wise. So you have to think randomly, and let's see what are the answers. So most of you are right. Naveen, this is not type 1. Yes. Hypersensitivity reaction for patch test. It is a type 4 hypersensitivity reaction. It is a type 4 hypersensitivity reaction. in which there are memory cells, and it is a cell-mediated immunity which is there. It is helpful to diagnose my contact allergic dermatitis. So it is based on the premise that the patient has already been exposed to the allergen. Next question, slab cheek appearance is seen in. So you're all right. Yes, it is parvovirus. Yes, it is erythema infectiosum. So it is seen in erythema infectiosum, and which is caused by parvovirus. Swimming pool granuloma is caused by, next question. Swimming pool granuloma is caused by Himadri, Shivangi, Thiruvathanam. You are all right. It is caused by a mycobacteria. And this is marinum. It is caused by, it is an atypical mycobacterial infection caused by M. marinum. It is a mycobacterial infection, but it is an atypical mycobacterial infection caused by M. marinum. Coming to the next question. Bocard's impetigo refers to, I'm sorry for the spellings here, it should be K here. Bocard's impetigo refers to. So what does Bocard's impetigo refers to? Don't worry, just write whatever you think is right. So just try to attempt here. There are no negative marks. Okay. Sam is attempting the next question, which is urticaria, which happens on exercising and sun exposure. And my third question in this slide is syringoma is a benign growth of which structure? So again, Himadri and Shelba, you are right. Bocard's impetigo refers to a staphylococcal infection of follicular ostium. So it is a type of superficial folliculitis which is caused by staphylococcus. So it is a staph infection of follicular ostium. Next question, urticaria which happens on exercising and sun exposure is, okay, so this was again to confuse you. It is not solar urticaria. What is it? Urticaria which happens on exercising and sun exposure. Another hint. So here I'm talking about an increase in core body temperature. When you exercise, there is an increase in core body temperature. Urticaria which happens on exercising or when the core body temperature is increased. Absolutely right. It is cholinergic urticaria. So remember, you might get confused here with sun exposure. If the question was just urticaria on sun exposure, then you will mark solar urticaria. But when the question says exercising also, that means I'm telling you about different situations where the core body temperature is rising. So here the answer would be cholinergic urticaria. Syringoma is a benign growth of which structure? Syringoma, absolutely right, Narsimha. Syringoma is a benign growth of sweat gland. Which kind of sweat gland? It is usually the eccrine sweat gland. It is the eccrine sweat gland. And typical histopath appearance in syringoma is a tadpole appearance. Absolutely right. Moving on to the next set of questions. Heliotrope rash is a feature of absolutely right. Everybody knows this. Heliotrope rash is a feature of dermatomyositis. Answer the next question, which is papillary microabscesses are a feature of. So you all know heliotrope rash. I'm so glad. Next question. Papillary microabscesses are a feature of. Where do you see papillary microabscesses? Okay, no. Okay. So it is not a feature of psoriasis or mycosis fungoides. Papillary microabscesses are a feature of dermatitis herpetiformis. There are different microabscesses that you should be knowing about. Potrier's microabscesses are a feature of mycosis fungoides. Papillary microabscesses are a feature of dermatitis herpetiformis. Next question. Acanthosis involves which layer of the skin? Acanthosis involves which layer of the skin? So which layer of the epidermis specifically? Acanthosis involves stratum spinosum, and it is usually seen in eczemas, right? So acanthosis is stratum spinosum. Don't confuse it with acantholysis that you see in vesicobullous disorder. Acanthosis is increased thickness of stratum spinosum. Next, cutaneous tuberculosis caused by contiguous spread from underlying foci is what is the cutaneous tuberculosis which is caused by contiguous spread? Absolutely right, Narsimha and Mushahid. It is scrofuloderma. It is a type of endogenous tuberculosis which happens because of contiguous spread from an underlying lymph node, a gland, a bone, or a joint. What next question? What are the FDA approved therapies for androgenetic alopecia? So I hope my pace is fine. If you want me to slow down or hurry up, you can tell me, we can do accordingly. So FDA approved therapies for androgenetic alopecia includes. So absolutely right. Again, it is both minoxidil and finasteride. It is both minoxidil and finasteride. So either of them in the option is correct for you. For females, it is 2% minoxidil. For males, it is 5% minoxidil. Remember. Feature, next question. Feature on Zang smear, sorry for the spelling again, of herpes genitalis patient, but not in a patient of pemphigus. So you do Zang smear for herpes and pemphigus. How do they differ? How do they differ? What is the feature that you will see in a herpes patient but not in pemphigus patient on a Zang smear? Absolutely right. You see multinucleated giant cells. You can see acantholytic cells in both the conditions, but a herpes patient will show multinucleated giant cell. Next question. Pterygium of nails is a specific feature of which condition? In which condition do you see pterygium of nails? Wonderful. It is not psoriasis. Pterygium of nails is a specific feature of lichen planus of the nail. And the most common feature is roughening, longitudinal ridging. But the most specific feature is pterygium. Next question. An epidermal nevus which appears during adolescence is. Yes, you're right. Pitting is the commonest feature for psoriasis. Pitting is commonest for psoriasis. Commonest for lichen planus is longitudinal ridging. Specific feature for lichen planus is pterygium. Specific feature for psoriasis is oil drop sign. Please remember these points. Next question. An epidermal nevus which appears during adolescence is. Oh, you all got it right. Absolutely. This is Becker's nevus. So it is an epidermal nevus which will appear during adolescence and is associated with hypertrichosis and pigmentation. Coming to the next question, which most of you have already answered. Classical histopath feature of mycosis fungoides is. You all have already answered this. Yes, it is Portrier's microabscesses. Portrier's microabscesses is the classical feature. So quickly revising, papillary microabscesses in dermatitis herpetiformis, Portrier's microabscesses and mycosis fungoides. Where do you see eosinophilic microabscesses? You can see it in bullous pemphigoid or pemphigus vegetans. Moving to the next question. Drug of choice for type 1 lepra reaction is? What is the drug of choice for type 1 lepra reaction? Absolutely right. Oral steroids are the drug of choice for type 1 lepra reaction. And usually in the exam, they will give you, do we stop MDT? No. You continue MDT and you give oral steroids. Very good. Next question. Bullous pemphigoid in pregnant female is called as? What is bullous pemphigoid in pregnant female called as? No, please don't get confused. What is impetigo herpetiformis? Impetigo herpetiformis is psoriasis happening in pregnant females. Bullous pemphigoid in pregnant female is called as herpes gestationis. Herpes gestationis. Please remember, impetigo herpetiformis is pustular psoriasis in pregnancy. Herpes gestationis is bullous pemphigoid in pregnant females. Next question. Cause of bindi dermatitis in females is? Divya, you're right. You can also call this pemphigoid gestationis or herpes gestationis. Both these terms are correct. Next question. Cause of bindi dermatitis in females. Most of you know it, right? It is para-tertiary butyl phenol. Para-tertiary butyl phenol. What is it for hair dye? Answer me quickly. The cause for hair dye, the chemical responsible for hair dye is? PPD. Absolutely right. For hair dye, it's PPD. For bindi, it is PTBP. Right. Next question. Best way to diagnose atopic dermatitis is? You all are very well prepared. I'm so glad to see that. Okay, so it is not patch test. Best way to diagnose atopic dermatitis is clinical evaluation. There is no test to diagnose atopic dermatitis. You follow the clinical criteria of Hannifin and Rajka. So it is clinical evaluation, right? Don't mark patch test, don't mark IgE. It is clinical evaluation. Treatment of choice for genital warts in pregnancy. What is the treatment of choice for genital warts in pregnancy? Okay. Yes, cryotherapy is the correct answer. Please don't mark podophyllin. Podophyllin cannot be given in pregnant females. So my treatment of choice is either cryotherapy or it can also be trichloroacetic acid. If you do not have facility for cryotherapy, you can do TCA application, but no podophyllin, please. Podophyllin is not used in pregnancy. Next question. Malignant pustule is a feature of? Yes, you're right, Shubham. It can be trichloroacetic acid. It can be cryotherapy, but no podophyllin. Next question. Malignant pustule is a feature of? Absolutely right. It is anthrax. And remember, it is not malignant and there is no pustule, right? So it is a manifestation of anthrax. So please like and subscribe this page if you're liking this session. Next question. X-linked recessive ichthyosis is caused by? X-linked recessive ichthyosis is caused by? a hint. It is caused by a deficiency of an, or you can talk about a gene or an enzyme. So, Jitain, transglutaminase is for lamellar ichthyosis. Okay, so X-linked recessive ichthyosis is caused by a deficiency of steroid sulfatase. Or you can say a defect in STS gene. All right. In ichthyosis vulgaris, filaggrin is the problem. In lamellar ichthyosis, transglutaminase is the problem. X-linked recessive ichthyosis, it is steroid sulfatase. Right? So that I will summarize. If we have time at the end of the session, you can remind me. If there is time, I'll quickly summarize that for you. So quickly revising the etiological factors, ichthyosis vulgaris, it is filaggrin. Lamellar ichthyosis, it is transglutaminase. X-linked recessive ichthyosis is because of deficiency of steroid sulfatase or a defect in STS gene. Next question, moth-eaten alopecia is seen in. Moth-eaten alopecia is seen in. Absolutely right. Yes, it is seen in syphilis, but you have to be more specific. It is a feature of secondary syphilis. It is a feature of secondary syphilis. Absolutely right. Max Joseph space is a histological finding that you see in which condition? In which condition do you see Max Joseph space? Amazing. Lichen planus. Lichen planus is the correct answer. Also, quickly summarizing, civet bodies are also a feature of lichen planus. Hypergranulosis is also a feature of lichen planus. And Max Joseph space or is also a feature of lichen planus. So all these are features. You can be given civet bodies also. Next question. Leash nodules are a feature of. Leash nodules are a feature of. You all got it right. It is neurofibromatosis type 1. Neurofibromatosis type 1. Scabies in infants differ from adults as it involves what site? Scabies in infants involves what site which is not involved in adults? Absolutely right. Face. It will not be genitalia, please. Genitalia can be involved in adults also. It is the face. And what is the clinical manifestation? What is the primary or a secondary skin lesion which you do not see in adults but can be seen in infants? Come on, answer that too. In infants, you can see one skin lesion which is not seen in adults. Any answers for that? Burrows can be seen in both. It is the vesicles. Shivan, you are right. It is the vesicles. You can see vesicles in infants, but not in adults because infants don't scratch. Adults scratch. Next question. STD, which is caused by a protozoa. Tell me an STD which is caused by a protozoa. That was quick, Siddharth. Trichomoniasis is the correct answer. So trichomoniasis caused by Trichomonias vaginalis is the correct answer, which is a protozoa. Next, dyskeratosis is a feature of which benign dermatosis? In which benign dermatosis do you see dyskeratosis? Dyskeratosis means abnormal keratinization, can be seen in both benign and malignant condition. I am talking about the benign conditions here. Himadri, you're absolutely right. It is seen in Darier's disease, but not in psoriasis. Please don't mark psoriasis. It can be either Darier's or Haley-Haley. Darier's or Haley-Haley disease. No psoriasis here. Dyskeratosis is not seen in psoriasis. It is parakeratosis which is seen in psoriasis. Next question. Most common cause of recurrent scaly hypopigmented patches on face in children is? Yes, in bovens also you can see dyskeratosis, but I mentioned a benign dermatosis, so that you have to remember. Yes. So it will not be P versicolor. Yes, it would be pityriasis alba. P alba presents with recurrent scaly hypopigmented patches. Next question. Row of tombstone appearance on histopathology is seen in. Where do you see row of tombstone appearance? Absolutely right. It is pemphigus vulgaris. You see separation of basal cells and they appear as row of tombstone. Next question. Most sensitive test to assess drug effectiveness or resistance in skin smears of leprosy patient is? Divya, fishnet pattern is seen on DIF. It is not seen on histopathology. On histopathology, you see row of tombstone appearance in pemphigus vulgaris. Most sensitive test to assess drug effectiveness or drug resistance in skin smears of leprosy patient. No, it is not the lepromin test. Lepromin test is not done on skin smears and it is an obsolete test. It does not tell you about drug effectiveness or resistance. What is it? Come on. It is the morphological index. Lepromin test will just tell me about the CMI, whether it is tuberculoid leprosy or lepromatous leprosy. It is a delayed type hypersensitivity reaction, which is kind of obsolete now. Drug effectiveness or resistance can be made out by doing a morphological index on slit skin smears of leprosy patient. All right. I hope it's clear to you. Morphological index would be the correct answer, where you actually count the number of solid staining elements, which are the live bacilli on a slit skin smear. Right? Moving on to the next question. Footprints in snow appearance is a feature of. Footprints in snow appearance is a feature of. It is not lichen planopilaris. Yes, you're right. It is pseudopelade of Brock. In lichen planopilaris, you see inflammation, you see follicular plugging. Pseudopelade of Brock, in turn, just present with cicatricial alopecia, which appears like footprints in snow appearance. Next question. Type of psoriasis which responds to antibiotics is. So it is not lichen planopilaris, it is not alopecia areata. Please remember, footprints in snow, pseudopelade of Brock. Type of psoriasis, next question, which responds to antibiotics is. Yeah, this you all know. It is guttate psoriasis. It can also respond to tonsillectomy because that can also be given as an option. So antibiotics or tonsillectomy, guttate psoriasis, because there's a role of streptococcus in it. Next question. Higoumenakis sign is seen in. Where do you see Higoumenakis sign? Absolutely right, syphilis. You have to mention congenital syphilis. And what type of congenital syphilis? It is seen in late congenital syphilis. So the complete answer would be late congenital syphilis. We all know late congenital syphilis has lot of these changes, Higoumenakis sign and other sign, frontal bossing, right? So late congenital syphilis. What is Higoumenakis sign? The medial end of the clavicle is enlarged. Next question. Intraepidermal immunobullous disorders are caused by formation of autoantibodies against what? Intraepidermal immunobullous disorders are caused by formation of autoantibodies against. You all are partly right. Here the answer would be desmosomes. Now, desmosomes are responsible for all kinds of intraepidermal disorders. Desmoglein 1 and 3 for pemphigus, desmocolin for IgA pemphigus, but the structure which is affected is desmosome. So if I ask you as a class, the answer would be desmosome. Next question, target lesions are seen in. You all are right. So it will not be BP antigen. BP antigen is subepidermal. Please don't get confused. BP antigen is for subepidermal disorder. Here we are talking about intraepidermal disorder. Now, all intraepidermal disorder target desmosomes and they target different parts of desmosome. So if collectively I ask you, it will be desmosome. If I asked you specifically for pemphigus, it would be desmoglein 1 and 3. If I asked you for IgA pemphigus, it would be desmocolin. If I asked you for paraneoplastic pemphigus, it would be desmoplakin. But if I have asked you in general, it would be desmosome, right? Target lesions are seen in. आपने WhatsApp किया है क्या? The target lesions are, you're right, it is seen in erythema multiforme, not in Lyme's disease. In Lyme's disease, you see something else, which will come soon. So target lesions are seen in erythema multiforme. Quickly answer me, what is the most common cause of erythema multiforme? The most common cause of erythema multiforme is, quickly give me an answer to that. Yes, it is HSV infection. Drugs are the second most common cause. The most common cause would be HSV. Next question, which genital ulcer does not involve lymph nodes? So, Yasavi, it's not drug reactions, it will be HSV. Drugs are the second most common cause, right? Next, which genital ulcer disease does not involve lymph nodes? Absolutely right, donovanosis. You see pseudobubos in donovanosis, which is development of lesions of donovanosis on lymph node, but per se, there are no lymph nodes which are involved in donovanosis. Now, next question. Erythema chronicum migrans is a feature of. Erythema chronicum migrans is a feature of what? Absolutely right, Sam. This is the one which you see with Lyme's disease. It is a cutaneous feature of Lyme's disease. So I hope it is clear. Target lesion you see in erythema multiforme, erythema chronicum migrans you see in Lyme's disease. Next question, most common endocrine disorder which is seen to be associated with vitiligo is? Yes, you're right. Lyme's disease is caused by Borrelia burgdorferi. That's also the correct answer. And yes, it is the thyroid disorders which are most commonly associated with vitiligo. If you ask me the commonest among the thyroid disorders, it is Hashimoto's. It is Hashimoto's. Next question. Annular herald patch is a feature of? So for vitiligo, it would not be Addison's disease. It is thyroid disorders, right? Annular herald patch is a feature of? Okay, yes, it is pityriasis rosea, not pityriasis versicolor. Commonly, we call it as herald patch, but you can also call it as annular herald patch. This is the first lesion which appears in a patient of pityriasis rosea. So it is pityriasis rosea. Yes, it is also called as the mother patch and there is collarette of scales on it. Next question. The most common cause of contact allergic dermatitis is? Yes, it is nickel. It is not detergent, it is nickel. So nickel is the most common cause of contact allergic dermatitis. And you should mark nickel as the answer. Rarest variety of pemphigus is? Which is the rarest variety of pemphigus? No, it is not pemphigus foliaceus. It is pemphigus vegetans. Pemphigus vegetans is the rarest variety of pemphigus. Remember this. Next question. Multiple painful penile ulcers with painful buboes are caused by which organism? Multiple painful penile ulcers with painful buboes are caused by which organism? Yes, so here I have asked you organism, so don't write chancroid. You have to say Haemophilus ducreyi. Haemophilus ducreyi, which causes chancroid, and chancroid presents like this. Now, some people are getting it confused with herpes. See, herpes does not usually present with ulcers. I would have written polycyclic erosions or coalescing vesicles with herpes. So if the question says painful penile ulcers, you have to mark H. ducreyi, which causes chancroid. Hair stays for maximum duration in which phase of hair cycle? Hair stays for maximum duration in which phase of hair cycle? Absolutely right. Anagen phase, which is the phase of hair growth. And the hair stays in it for 3 years. Telogen phase is the phase of hair fall. The hair stays in it just for 3 months. And the shortest is the catagen phase or phase of transition, in which the hair stays for 3 weeks. So here the answer would be anagen phase. Kogog's pustule is a feature of which condition, and you see it in which layer of the skin? So 2 questions here. Answer both. Kogog's pustule is a feature of which condition, and you see it in which layer of the skin? Yes, it is psoriasis, so it is seen in psoriasis. Both Monroe's microabscesses and Kogok's spongiform pustules are seen in psoriasis, but there is a difference in where they lie. Monroe's microabscesses lies in stratum corneum. Kogok's spongiform pustules rise in stratum malpighi. To be more specific, it should be stratum malpighi, which includes both stratum spinosum and stratum basale. So you are right when you see stratum spinosum or basale. So to give one answer, you can see stratum malpighi, which is, what is stratum malpighi? It is spinosum and basale both, right? Next question. Castle's necklace is a classical clinical feature of which condition? Castle's necklace is a classical clinical feature of which condition? Absolutely right. Somehow they always ask you about pellagra in the exam. So yes, it is a clinical feature of pellagra, which is caused by deficiency of niacin, and there are 4 Ds associated with it: dermatitis, diarrhea, dementia, and eventually death. Next question. Which color kit will you use in a patient with urethral discharge? This was again a question. Gray color kit, absolutely right. Gray color kit or kit 1 is one which you use for urethral discharge patients. Next question. Spongiosis is seen in which layer of skin and is seen commonly in which condition? 2 questions here again. Spongiosis is seen in which layer and is commonly seen in which condition? Absolutely right. Spongiosis is seen in stratum spinosum. And which clinical condition do you see spongiosis in? You see it in eczema. What kind of eczema? Acute eczemas. So acute eczema shows spongiosis. And what is spongiosis? It is intercellular edema. It is intercellular edema. Next question. Treatment of choice for tinea capitis is, forgive me for the spelling here, it is tinea capitis. Treatment of choice for tinea capitis is? Yes, absolutely right. Griseofulvin. Griseofulvin is now used only for tinea capitis, and it still remains the drug of choice there. Now, next question. Which primary or secondary skin lesion is never a manifestation of secondary syphilis. In secondary syphilis, you can see all kinds of lesion, but you do not see one kind of lesion. What is that? You guys are amazing. You are all well read. I'm so glad. Yes, it is vesicles and bullae. So you do not see vesicles in secondary syphilis, but you can see it in congenital syphilis, which is also called as syphilitic pemphigus. It is a feature of congenital syphilis, but never seen in secondary syphilis. Next question, urticarial lesions can be a manifestation of which immunobullous disorder? In which immunobullous disorder you can see urticarial lesions? Come on, think. No, it's not vulgaris. Okay, I'll give you a hint. That immunobullous disorder has a pre-bullous stage, which is characterized by development of urticarias. No, not linear IgA, not DH. Think. It is also called as the pre-bullous stage or the urticarial stage. Yes, Prem, you are right. It is bullous pemphigoid. So remember, students, bullous pemphigoid usually has a pre-bullous stage in which the patient presents with urticaria. That's why in bullous pemphigoid you see eosinophilic microabscesses, right? So urticarial lesions are manifestations of bullous pemphigoid, right? I think only Prem got it right. Well done, Prem. Next question. Which drug causes ichthyosis-like features and also reddish discoloration of skin? Which drug can cause ichthyosis-like features and reddish discoloration of skin? No, it's not vancomycin. It's not vancomycin. It is not bleomycin. Think. No, it is. So, okay, are we jumping to the next question, Sam? Himadri, you are absolutely right. Clofazimine. Clofazimine is the drug which causes ichthyosis-like features and reddish discoloration of the skin, and we use it for leprosy. Next question, most common cause of plant dermatitis in India. One of you already, Sam already gave me the answer. Yes, it is Parthenium hysterophorus. Parthenium hysterophorus is the most common cause of plant dermatitis in India. Very good. Next, ecthyma gangrenosum is caused by. What causes ecthyma gangrenosum? Pseudomonas is the correct answer. Ecthyma pseudomonas, ecthyma gangrenosum. But ecthyma infectiosum is strep and ecthyma contagiosum is pox virus. Remember, gangrenosum, pseudomonas aeruginosa. Next question. Read it carefully. Drug which is used for unresponsive type 2 lepra reaction in an uncontrolled diabetic patient. Which drug will you use in an unresponsive type 2 lepra reaction in uncontrolled diabetic patient? Yes, it would be thalidomide here. Now remember, the drug of choice for type 2 reaction is steroids. It is steroids. But here, look at the question. I'm saying it is unresponsive and the patient is uncontrolled diabetic. In this situation, you will use thalidomide, which is my second line of treatment for type 2 lepra reaction. No, it would not be steroid here because I've mentioned unresponsive and I've mentioned uncontrolled diabetic. So please look at the question carefully and then answer. That was the purpose of giving you this. Next question. Sheets of erythema with islands of normal skin is a feature of. The way you're right, it is the drug of choice, but here I'm not asking about the drug of choice. I'm asking that it is an unresponsive type 2 lepra reaction. So unresponsive means it has not responded to the first class of drug that I gave. And second is, I've said it is uncontrolled diabetic. Okay. So I hope that should be clear. Next question, sheets of erythema with islands of normal looking skin. In which condition do you see this? No, it's not erythroderma. Come on, give me more answers. So I think you got confused here. It would be PRP or pityriasis rubra pilaris. It is not dengue. It is not LPP. Pityriasis rubra pilaris patient presents with sheets of erythema, and in between there are islands of normal looking skin. Whenever they say islands of normal looking skin, please remember it is PRP. Few other features of PRP is PRP sandal that you can get. Okay. Next, Vismodegib is used in the treatment of. Where do you use Vismodegib? It is not malignant melanoma. Yes, it is basal cell carcinoma. It is a hedgehog pathway inhibitor that we use in patients of BCC who cannot go for surgical removal. Best treatment for telogen effluvium is. What is the best treatment for telogen effluvium? Let's be quick now. Okay. So best treatment for telogen effluvium is counseling and biotin because it resolves on its own. So you do not need any treatment. And if you have to give anything, you give multivitamins like biotin. So absolutely right, counseling. Treatment of choice for psoriasis in HIV positive patient. Psoriasis in HIV positive patient, what will you give? Till you answer that, for dye spots, we have already discussed. These are what? This is ectopic sebaceous gland. We already discussed this in the first slide. Treatment of choice for psoriasis in HIV positive patient is acitretin. Please don't write isotretinoin. Isotretinoin is used in acne. Acitretin is the drug of choice in HIV positive patient. Otherwise, the drug of choice for psoriasis is methotrexate. But in HIV positive patients, you give acitretin. Next, multilocular painful buboes with discharging sinuses are seen in which STD? Where do you see multilocular painful buboes with discharging sinuses? No, it is not H-Ducry. It is LGV. Now remember to differentiate between chancroid and LGV buboes. LGV is multilocular, it is painful, it is not associated with ulcer. Chancroid all use unilateral, unilocular and ulcer. So here the answer would be LGV. Which test helps to differentiate between nevus anemicus and nevus depigmentosus? Absolutely right, all of you. LGV, which is associated with groove sign. Next question. How do you differentiate nevus anemicus and nevus depigmentosus? What is this test called? You're all right, but this test is called as dioscopy. You're right, it is the slide blanching test. The test is called as dioscopy. Okay? Fishnet pattern of immunofluorescence is a feature of. Fishnet pattern. It is not ichthyosis. Yes, it is pemphigus. Specifically, pemphigus vulgaris can also be seen with foliaceous. Very good. Next, an ichthyosis which mainly presents on extensors and is associated with atopy. Which ichthyosis present with on extensors and is associated with atopy? No, 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 not lamellar. Lamellar is associated with colloidal baby. It is associated with ectropion and eclabion. It is associated with fish plate scales and erythroderma. This is Ichthyosis vulgaris. Quickly revising here. Vulgaris seen on extensors associated with atopy. X-linked recessive ichthyosis is seen on flexures on preauricular area and is associated with cryptorchidism and comma-shaped opacities. Lamellar ichthyosis associated with ectropion and eclabion and colloidal baby. Right? So I've quickly revised ichthyosis here. Hereditary angioedema is caused by deficiency of, very good, C1 esterase inhibitor. C1 esterase inhibitor, okay? And you've already given me the answer to the next one. Classical histopath feature of molluscum contagiosum is, yes, you're right, it is Henderson-Peterson bodies, which are eosinophilic inclusion bodies that you see in molluscum. Very good. Cradle cap is a special form of which dermatosis? Where do you see cradle cap? It is, no, where, I'm not asking where do you see it. It is a special form of which dermatosis? Cradle cap. Absolutely right. Seborrheic dermatosis. The most effective drug for M. lepra is, which is the most effective drug for M. lepra? So it is not Kirion. Please remember, it is not Tinea capitis. It is seborrheic dermatitis. The most effective drug is rifampicin. It is not dapsone. Rifampicin kills 99.9% of bacilli in one dose. So the most effective drug is rifampicin, but we give multi-drug therapy to prevent the chances of resistance. Burrows and scabies are seen in which layer of the skin? Where do you see burrows in skin? Absolutely right. Stratum corneum. Remember, burrows can extend up to stratum malfigi, but they're seen on stratum corneum. Ridley-Joplin classification does not include what two types of leprosy? Ridley-Joplin classification does not include what two types of leprosy that we commonly see? Very good. It is indeterminate. What is the other type? So it does not include indeterminate type of leprosy and pure neuritic. Amazing. Yes, it is pure neuritic and indeterminate type. Most common causative organism for tinea capitis. You all are absolutely right. Moving to the next question. Most common cause of tinea capitis. Absolutely right. It is T. tonsurans. Earlier, it was considered Microsporum canis, but now it is Trichophyton tonsurans. Next, Shankar redux refers to. What does Shankar redux refers to? To make it more simpler, which stage of, yes, no, it is not gamma occurring at the site of Shankar. Gamma is called as pseudo Shankar redux. Shankar redux refers to relapsing syphilis. So when relapsing syphilis occurs at the site of old Shankar, it is Shankar redux. When gamma occurs at the site of old Shankar, it is called as pseudo Shankar redux, right? Next, oral steroids are indicated in which type of psoriasis? We do not recommend oral steroids in psoriasis, but there is one type where you give oral steroids. What is the answer to that one? Yes, so you will not say just pustular psoriasis. You will say pustular psoriasis of pregnancy, which is also called as impetigo herpetiformis. So pustular psoriasis of pregnancy or impetigo herpetiformis is the only indication where we use oral steroids in psoriasis. What is seen at the periphery of alopecia areata patch? Very, very easy question. What do you see at the periphery of alopecia areata patch? Exclamation mark here. Absolutely right. Inheritance of incontinentia pigmenti is absolutely right. Inheritance of incontinentia pigmenti is X-linked dominant. Amazing. You guys know everything. X-linked dominant, one of the rare conditions, right? So that's why I put in here. Which lasers are used to treat dermal melanocytic nevi? Which lasers do you use to treat dermal melanocytic nevi? It is X-linked dominant and not autosomal dominant. Remember that. Absolutely right. So you can use either Q-switched Nd:YAG or ruby laser or alexandrite laser. All of this is correct. Asteroid bodies are commonly seen in which condition? No, you do not use CO2 laser here, Siddharth. You use Q-switched Nd:YAG, you use ruby or alexandrite laser. Asteroid bodies are commonly seen in, not in sarcoidosis, you see it in sporotrichosis. Sporotrichosis or sporothrix kenkai, absolutely right. You can see it also in sarcoidosis, but if you have to mark one, mark sporotrichosis. Treatment of choice for mycosis fungoides is? What is the treatment of choice for mycosis fungoides? Electron beam therapy. Absolutely right. Electron beam therapy. Next, hypopigmentation in pityriasis versicolor is due to? What is hypopigmentation in pityriasis versicolor due to? No, it's not lipase. It would be azelaic acid. You're right. Azelaic acid is responsible for hypopigmentation. You can also write carboxylic acid here. Right? Next question. Ash leaf macule is a feature of. Where do you see ash leaf macule? Easy one. Tuberous sclerosis. First sensation to be lost in leprosy is? Which is the first sensation that is lost in a leprosy patient? Temperature. Absolutely right. There is loss of temperature that happens. Wavelength of narrowband UVB therapy is? You all are absolutely right. Temperature, cold more than the hot. Absolutely right. What is the wavelength of narrowband UVB therapy? It is 311 to 313 nanometer. Again, absolutely right. Clue cells form part of which criteria and are used to diagnose which condition? Which criteria and which condition? Yes, you all are right. It is 311. No 370, no 365. 365 it's for Woods lamp. Amsel's criteria, absolutely right. And this is used to diagnose bacterial vaginosis. Amazing. Which lines follow the lines of embryonic migration in skin? Which lines follow the lines of embryonic migration in skin? Very good. Yes, it is the Blaschko's lines which follow the lines of embryonic migration. Langer's line are the lines which follow the orientation of collagen bundles and muscle fibers. Embryonic migration, it is Blaschko's lines. Absolutely right. Podophyllin is used for treatment of. Where do we use podophyllin? I think this would be an easy one for you. Yes, which particular type of warts? So you have to say here genital warts. We use podophyllin for genital warts. We don't use it for other types of warts. Itch is a disease. Is true for which disease? For which disease do we say that itch is a disease? Yes, absolutely right. Genital warts caused by HPV 6 and 11. Itch is a disease is not true for scabies. It is not true for scabies. Yes, it is true for atopic dermatitis, not for tinea, not for scabies, not for eczemas in general. It is true for atopic dermatitis. Mucus patches are a manifestation of. Where do you see mucus patches? Mucus patches are a manifestation of. No, it's not pemphigus vulgaris. It is not lichen planus. Yes, Himadri, that's right. It is a manifestation of secondary syphilis. Again, it is a mucosal manifestation of secondary syphilis. Lichen planus presents with reticular white patches. Lacy reticular pattern is seen in lichen planus. Mucus patches are feature of secondary stage of syphilis. In pure neuritic Hansen, nerve biopsy is done from which nerve? Where do you do nerve biopsy in a patient of pure neuritic Hansen? Yes, nail tract lesions are also a mucosal manifestation of secondary syphilis. Sam, you're right. Okay, please don't write ulnar nerve ever. You have to write two nerves. It can be either radial cutaneous nerve or sural nerve. You have to do it from purely sensory nerves. So please don't write ulnar nerve. You do it from radial cutaneous nerve or sural nerve, which are the sensory, purely sensory nerves, right? Rhinophyma is, next question. Rhinophyma is, yes, it is superficial radial cutaneous nerve or sural nerve, not from greater auricular nerve, not from ulnar nerve. Siddharth, you're right, it is potato nose, but what is it actually? Where do you see it? It is glandular rosacea. Rhinophyma is another term that we use for glandular rosacea. Right? Next, sclerotic bodies are seen in. I'll give you another hint here. Sclerotic bodies or copper penny bodies are seen in which condition? Oh, you didn't need the hint. It is chromoblastomycosis. It is chromoblastomycosis. Wonderful. One melanocyte transfers melanosome to how many keratinocytes around it? One melanocyte transfers melanosomes. Yes, it is also called as medullary bodies, copper penny bodies, or sclerotic bodies. You're all right. Yes, it is 36 keratinocytes, and this is called as one epidermal melanin unit. When one melanocyte transfers its melanosome to 36 keratinocytes. Circinate balanitis is a feature of. Where do you see circinate balanitis? No, it is not seen in Candida. Circinate balanitis is a specific term that you use for a particular condition. No, it is not Candida. Give me some other answer. No, it is not diabetes. It is a feature of Riter's disease. It is a feature of Riter's disease. Keratoderma blennorhegicum and circinate balanitis are features of Riter's disease. Please remember, it is not tinea, candida, HPV. Divya, you are right, it is Riter's disease. Next, Geographical lesions are seen in which spectrum of leprosy? In which spectrum of leprosy do you see geographical lesions? You can also call it reactive arthritis, absolutely right, or Rita's disease. Geographical lesions are seen typically in BB leprosy. In BB leprosy. All right. Geographical lesions are seen in BB leprosy, geographical or map-like configurations. Last 3 questions for you. These are the last 3 questions for today. Favus is caused by inverted saucer. Okay. Yes. Inverted saucer appearance. If I would have given, you could have said BL. Pseudopodia, BT. Satellite lesions, BT. Geographical lesions, map-like configurations, BB. Favus is caused by easy one. It is caused by Trichophyton conleni. Sweet syndrome shows presence of which cells on blood smear and also on histopathology. In sweet syndrome, which cells are present on blood smear and also on histopathology? Neutrophils, absolutely right. It is a neutrophilic dermatosis, and so you would see neutrophils here. Geometrical shallow pits are a feature of. Where do you see geometrical shallow pits? Amazing. Alopecia areata. You're right. So pits, though, are a feature of psoriasis, but there they are deep, they are random, they are irregular. In alopecia areata, you see geometrical and shallow pits. So that brings me to the end of this session. I thoroughly enjoyed it, and you guys are really well read. I'm so glad to see that. And all the best for your exam. I'm sure you're going to rock it, and you're all clear about dermatology. And just like and subscribe the page if you like this session, and keep posting me your queries. I can answer them, and it would keep us connected. All the best for your exam, and I end the session here. Okay, so that's okay. So before I finish, different types of ichthyosis I already covered, Siddharth. There are 3 main kinds of ichthyosis. Vulgaris, associated with atopy. Scales are on the extensors mainly. Lamellar ichthyosis, which is associated with colloidal baby, ectropion and eclabion. And there you see fish plate-like scales, or you see erythroderma. X-linked recessive ichthyosis, it's very dirty looking scales, mainly present in the preauricular area, on the neck, on the body. It can be present on any part of the body, and it is associated with cryptorchidism and comma-shaped opacities. I'm sorry, I'll not be able to provide the PDF, but this YouTube video would be available for you to watch at any time. Mohit, sure, short topics for derma. I think that was the purpose of this session. All these one-liners are one of the commonly asked questions or topics from dermatology, and that's why we discussed them there today. Right? So I think I'll close the session here, and it was a lovely session. Take care, keep studying, and I'm sure you would pass with flying colors.